Good evening, guys. Dr. Mukul here, your orthopedic instructor here at Unacademy. I hope the audio visual is going well. So just need your guys thumbs up to let me know that the audio visual is okay, which means you can see me, you can hear me, you can see what is being presented on the board. Okay. So I hope the audio visual is okay. Perfect enough. So I think that's all okay. So I think we can just quickly get started. Now this is a session where I have aimed to present some MCQs, and the topic I am going to focus up the ligament injuries of the knee, a very important area that you cannot afford to miss in case you're going for your orthopedics exam. So I'll try to focus on these areas and simultaneously would like to discuss some MCQs from the same area. Starting first up with this particular question. Patient has sustained a hyperextension injury at the knee 2 days back. The knee is having hemarthrosis. Hemarthrosis means blood in the joint. Now this blood in the joint would generally distract the capsule, and capsule is the most pain sensitive structure in the joint. So with hemarthrosis, you expect the knee to be painful. Now in this scenario, just 2 days old injury where the knee is painful, I want you guys to help me out as to which will be the most appropriate clinical test to be performed in this scenario. The Latchman test, the McMorris test, the anterior row test, or none of the above tests should actually be performed, because it's a painful knee. Avoid touching a painful knee. So people watching, your comments are always welcome. There is no negative marking in my class. So whatever you wish to say, please feel free to communicate with me. So I'll come back to this question in a while till you're preparing your mind. Meanwhile, so that we can answer this question, let me give you some kind of an understanding about the ligaments that stabilize the knee. Now, running on the sides of the knee, you have these collateral ligaments. On the medial side, you have the medial collateral ligament. On the lateral side, you have the lateral collateral ligament. Now, running in the center of the knee and crossing each other in the shape of X, you have the cruciate ligaments. This one in the front is the anterior cruciate ligament, and this one at the back is the posterior cruciate ligament. Now, when you pull the femur up and you push the tibia down, on top of tibia you have these C-shaped articular cartilage discs, and this is what we basically call as the menisci. There is the medial meniscus and there is the lateral meniscus. Fine enough. So in a simple way, knee joint is stabilized by 3 group of ligaments: the collateral ligaments, the cruciate ligaments, and of course eventually the menisci. Fine. Okay. Now let me first brief you about how a particular ligament helps in stabilizing the knee. See, the collateral ligaments are basically running on sides of the joint. So when this tibia is going to get a medial lateral tilt, or you can say a varus or a valgus tilt, the collateral ligaments are going to help out and resist that force. Like in a simple way, suppose this tibia tilts medially. This is a varus tilt, in a simple way what we call it. So when this tibia will tilt medially, this lateral collateral ligament will prevent that tilt. And quite in a similar fashion, if the tibia tilts laterally, we call this as a valgus tilt. This valgus slipping of the tibia will be resisted by the MCL. So these collateral ligaments, they aim to provide this varus valgus stability to the knee because they are running on sides of the joint. Pretty much imaginable now. Simple way. Now the cruciate ligaments have a different anatomy. See this diagram very nicely. So this is ACL, and at the back is what you have the PCL. Now you can see ACL is going and attaching to lateral condyle of femur, and PCL is attaching to medial condyle of femur. So they're crossing each other mediolaterally. Now let me tell you, these ligaments also cross each other anteroposteriorly. Like if you see this ACL, it's beginning right in front on the tibia, and then it is going back, and then inserting on femur. So ACL is going from front to back. But if you notice this PCL, it must be starting somewhere on back on tibia, and then you can see it is coming in front to attach on femur. So ACL goes from front to back and PCL goes from back to front. So if you talk about these cruciates, so this is a ligament I have shown over here that is starting in front on tibia and going back to insert on femur. So if you see here also, a ligament that is starting in front on tibia and going back to inserting on femur is simply the ACL. So you can very well imagine that if this tibia goes in front, like I've shown over here, the ACL will get elongated. So ACL prevents the tibia from going forwards, okay, in the cruciates. And if you look at the PCL, a PCL would just be the opposite. It will be beginning on back on tibia and then going in front and attaching on femur. So what I've drawn in this color, pink color, is PCL, and if you push this tibia back, it is going to stretch the PCL. So PCL will prevent this tibia from slipping back. So if you talk of the cruciate ligaments, they are providing you the antero-posterior stability in the knee. So clear enough, guys, with these two group of ligaments. So tibia does not slip anteriorly, ACL stops it. Tibia does not slip posteriorly, PCL stops it. Tibia does not sag into varus or valgus, the collaterals stop it. Now you can see this meniscus here. It is running on sides of the tibia, converting these flat tibial surfaces into sockets so that the condyles of femur lock into these sockets, so that their rotation is jammed. So that is what is the purpose of the meniscus. It aims at providing you the rotational stability in the knee. Clear enough, guys? Okay. So can I just get a thumbs up if you guys are clear with the function of the three group of ligaments? So collaterals running on the side would prevent this sideways stability, give you the sideways stability. Cruciates going from front to back and back to front, they are definitely in a simple way going to prevent this tibia going forward and backward. So they are going to provide you the anterior posterior stability in the knee. The meniscus is going to give you the rotational stability in the knee because it's covering the edges of the tibia, allowing the femoral sockets to lock into the tibial sockets perfectly. Now once you are clear with these the purpose of these ligaments, it becomes very easy for you even to understand what injury would tear a ligament. See, what I have shown over here is a valgus injury to the knee, and what I have rather shown over here, a varus injury to the knee. Now you can very well imagine that if this tibia will go laterally into valgus, it will break the MCL here. And you can very well imagine that if this tibia will go in a medial direction, so this will be tibia going medially because this is fibula. Fibula is a lateral bone. So if the tibia goes medially, it will stretch up this LCL. Okay. So tibia here is going medially. So I am calling it a varus injury. Tibia here is going laterally. So I am calling it a valgus injury. Clear how to decide varus and valgus injury? And clear with the fact that when you will have a valgus injury, it will be a tear of MCL. When you will have a varus injury, it will be a tear of LCL. So varus valgus injuries would end up tearing the collaterals. Like see this picture here. This gentleman hitting from the side. So you can see distal to the knee, the leg has gone laterally. So this type of injury will be labeled as a valgus injury. And if it will be a valgus injury, I need not tell you the ligament that is going to be torn over here, it is going to be the MCL. So clear with few of these examples. So varus valgus injuries would tear the collaterals. Now if you see the scenario here, you have understood that tibia goes forwards, it will tear the ACL, tibia goes backwards, it will tear the PCL because of the anatomy of these group of ligaments. So if you have understood this much, now let me just show you this very nice picture. This gentleman is trying to run away with the ball, and this gentleman thinks too difficult to stop the ball, let us stop the player. So he's tried to stop the player, and you can note distal to the knee, the leg has gone anteriorly. Because what has happened at the knee is hyperextension. Clear enough? Okay. So just explain to you the anatomy again, in case you want, Gautam. ACL is running from front to back on tibia to femur. So ACL begins on tibia in the front, goes back to insert on femur. PCL begins at the tibia at the back, comes in front to attach on femur. So one is running from front to back, another one is running from back to front. So they are crossing each other in the anterior posterior direction. I've just tried to show the two ligaments on this diagram very nicely. Running from the front to back, this is the ACL, and running from back to front, this is the PCL. So tibia goes forwards, the ACL stretches up and stops it. Tibia goes backwards, the PCL tightens up and stops it. Now if you will have a hyperextension injury, the tibia will go in front. Tibia will go in front. Like you can see, distal to the knee, tibia gone in front. Now tibia will go too much in front, the ACL will tear. So I think now that makes sense to you, that if there will be a hyperextension injury, you are going to find an ACL tear. And a hyperflexion injury will just be the opposite. If you flex this knee, like you can see over here, this is hyperflexion. So tibia is going to go back. So this is going to tear the PCL. Got it, Gautam? So extension injuries tear the ACL and flexion injuries tear the PCL. Clear enough with that also, guys? And when you have eventually the rotational injuries that we call as the twisting injuries, this is where you find meniscal tears. Because meniscus is what lies exactly in between the two condyles. So when the two condyles rotate on each other, you land up with meniscal tears. I've just shown you this very nice diagram. See this meniscus lying between the femur and tibia as a washer, as a rubber. So if the condyles would rotate between each other, this meniscus is going to be knocked out. So rotational or twisting injuries would generally lead to meniscal tears. But yes, most of the times when you get injuries in sports, a combination of forces act together. Like see this picture. This gentleman is trying to pick a ball. So he's suddenly going to get up. As he's going to get up, suddenly his knee is going to get an extension jerk. So that extension jerk will end up tearing the ACL, because extension tears the ACL. See, as he's trying to pick a ball, the knee getting rotated, and see the knee going into the leg going into relatively valgus, because what you're going to find at the knee, the leg will go laterally because of this push of the body weight. So there will be valgus at the knee. So this valgus will end up tearing the MCL, and this rotation will end up tearing the medial meniscus. Now when this kind of an injury pattern happens, you get this combination that I've just shown in front of you. This is what you call as O dono yugs triad of knee injury. So this is the most common combination of knee injuries, ligament injuries that we find in our clinical practice. The unhappy triad, absolutely right. Okay. So Gautam, in case someone is hit right from the front by a bike, and that bike hits on the tibia goes back, it will tear the PCL. Well, Gautam, what we are speaking of could have been spoken in one word as what you call as a dashboard injury. Dashboard injury. Maybe I can just try to replicate that for you. So you are sitting in the car. So this will be your knee, and that will be your foot, and you will be sitting like this. All of a sudden, brakes are put on and something hits your knee. This tibia is going to go back, and you're going to land up with a PCL tear. Clear, dear? So absolutely right, dear. So posterior dislocation of the hip, patellar fractures, PCL tears, all three are possible when you have this dashboard pattern of the injury. Perfect enough. So you've understood the mechanisms very well. Wonderful. Now let me also tell you how do we tend to test each of these ligaments. See, when you have these collateral ligaments torn, we test them by the stress test. You hold the leg in one hand and then you give a varus and a valgus twist to the leg. If a particular collateral ligament is torn, you can move the leg to a greater extent on the opposite side. Like if the MCL is torn, this leg will move a lot to the lateral side because the MCL cannot resist that stress. It's broken. You can always compare with the other side. So for collateral ligaments, you need to know about the stress tests, and they are best performed in 30 degree of knee flexion. Like you can see over here, the foot has been taken, the leg has been taken away from the table to flex the knee to around 20-30 degrees. Clear enough? So the joint space on the middle side would widen because this leg would go laterally. Perfectly okay, dear. Perfectly okay. Fine. Now collateral ligaments you will test by stress tests. How to check for cruciate ligaments also, I think I should tell you. For cruciate ligaments, checking the ACL and PCL both is required. Now the standard test for ACL has been the anterior draw test, and that's the anterior draw test being performed. The hip is flexed almost to 45 degree, but mind you, the knee has been flexed exactly to 90 degree. So here you have like 90 degree of knee flexion in the anterior draw test. Now the surgeon is holding this proximal tibia, and to check for the ACL, this surgeon is going to pull towards his side. He pulls it, he finds more anterior movement of the tibia as compared to the normal side, means the ACL of this side is torn, it is not able to hold the tibia from going anteriorly. So this is what you call as the anterior draw test. But the problem with the anterior draw test, that it is not suitable for cases of acute injury, because acute injury very difficult to achieve 90 degree of knee flexion. Even let me tell you the bigger problem than this, okay, if it's a case of acute injury, just a second, little bit of problem on my side. Yeah, so if it's a case of say acute injury, what we basically find that the hamstring tendons at least sometimes tighten up, and they prevent this anterior movement of the tibia in 90 degree of knee flexion. So a variation of the anterior draw test exists that is performed just in 20 degree of knee flexion, that is Lachman test, where you hold the femur in one hand, the tibia in the other, and then you try to pull and see that anterior translation. So when you do this test in 20 degree of knee flexion, it becomes very much suitable even for a case of acute injury. So I hope you guys are like thoroughly okay now. Okay, so 90 degree flexion anterior draw test is difficult in acute injury. So if you have to check an acute injury for ACL, go with Lachman test. For PCL, it is the same as anterior draw test, but rather than pulling, you are going to push and check a posterior sac. So PCL will be checked simply by the posterior drawer test. Clear enough, guys? Checking for the meniscus. One is McMurray test. Keep one hand on the knee, hold the foot in the other hand, flex till the chest extend, flex till the chest extend. You hear a thud, a click on your hand, meniscus is torn. So this is McMurray test. Another one is Apples test, where you make this patient lie prone, you bend this knee to 90 degrees, hold the foot, and here you rotate the foot to grind the knee. So this is basically a grinding test. You rotate the foot to grind the knee. If there is a meniscal tear, there will be pain. Patient will shout in pain. So this is how you can check for meniscal tears. But the problem with both these tests is that they tend to be very, very painful. So a better way to check for the meniscus is just to look for joint line tenderness. See, the joint line is all formed by the meniscus. A collateral ligament is just a vertical strip. So you are pressing along the joint line, you find tenderness, it is meniscal tear, and joint line tenderness is taken to be the best way to check for meniscal injury. Clear? Now if you are clear with the 30 degrees. Okay, I couldn't get you what you are saying 30 degree. Latchman test is not 30 degrees, it's 20 degrees. Please be very clear. Okay, fine enough. All right. So Gautam, ring fracture, Jefferson fracture are different. Ring fracture is base of skull fracture. Jefferson fracture is C1 vertebra fracture. So don't mix the two. I'll tell you how to ask me those questions also in a while. Okay, fine enough. Perfect enough. Perfect enough. Perfect enough. So I'll just move up and go back to this question. Now, patient has sustained hyperextension injury at the knee. So I don't think I need to tell you what ligament is torn. ACL. Now this is just 2 days back acute injury, knee is painful. So which will be the best test to perform? No test can be performed? No, not the correct answer. McMurray test, we have just spoken of it. It is a test for meniscal tears. So that is also the answer, because we are dealing with a case of ACL tear. So Latchman and anterior drawer are the only options that are suitable over here. And since it is acute painful knee, the better test is going to be Latchman test, because all you need is just 20 degree of knee flexion. So very easily clear with this particular one question. Okay, the problem in the anterior drawer test we have just discussed, that it requires so much of knee flexion, so not suitable in acute injury. So acute injury, more suitable would actually be the Latchman variant. So clear Debraj, clear Gautam. So clear with these points. So can I just now move ahead and take up another one? Fine. Okay. So if you understood how to check each ligament, now you have checked each ligament, you know that you are dealing with maybe a meniscal tear. So you are dealing with a peripheral tear of the meniscus. What would be your option here? Like what would you like to do for this peripheral tear of the meniscus? A question from one of the AIMS exam, a similar question came up. So can you just help me out here? Like what would you like to do for a peripheral tear of the meniscus? Conservative exercise. Okay, I'll tell you. See, if you have a meniscal tear, you have to decide, are you dealing with a peripheral tear or are you dealing with a central tear? A peripheral tear is in a vascular red zone and a central tear is in a avascular zone. Like see this very nice diagram. The center of the meniscus has no vascularity, the edge has a vascularity, red zone. So peripheral tears make sense in repairing. It is the central tears that you excise. Excision of a meniscus, we simply call it as like meniscectomy. So for central tears you can plan meniscectomy, not for peripheral tears. Here it's a case of peripheral tears for repair. Clear with that, guys? Simultaneously, I would just like to tell you about other ligaments also. Just in case you're dealing with isolated collateral ligament tears, this is where you can speak of treatment being conservative. Clear there? So conservative for collaterals, they heal. And just in case you're dealing with tears of the cruciate ligament like ACL or PCL, so what you have to do over here, ligament reconstruction. I'll just explain this part to you. See this here, a tendon. This is a hamstring tendon I have taken, semitendinosus, a spare hamstring. I have drilled tunnels in the tibia, drilled tunnel in the femur, and with the help of a rope I am pulling this tendon graft into these tunnels and I am going to fix it at the edges with screws. So inside the knee, this graft will be occurring, replacing a natural ACL. So what you do in ligament reconstruction, you replace natural ligament with a tendon graft. So when you replace the natural ligament with a tendon graft, that is where you say that we have done ligament reconstruction. So cruciates are reconstructed, collaterals dealt conservatively, and meniscus, depending on peripheral or central tear, dealt accordingly. So are you guys clear even with the treatment in these ligaments? So clear why not conservative treatment for a peripheral tear? Okay, because it is vascular, so if you repair it will very well heal. Well, a tear at the edge cannot be treated conservatively, because when you walk, you load the meniscus. Meniscus is right in between the two condyles, so keep on loading, it will keep on tearing more. Collateral ligaments are not loaded as you bear weight, so they can be dealt conservatively. Clear enough there? Fine. One last one. 21 years old male has been brought to your emergency, sleeping while catching a ball in the cricket match. there was some tibial torsion that occurred during this fall. So torsion means this twist in the tibia. So which of the falling also has a risk of getting injured with this injury? So anyone wants to try their hands onto this one? Which structure could get injured over here? B. Lateral patellar subluxation people have. Okay. Any more people who wish to try? So let me tell you, Gautam, you are absolutely right. This is the blinder. Even without looking at the question, you can answer it's lateral patellar subluxation, but I'll just like to tell you the mechanics here. This is a case of patellar dislocation. See, dislocation in patella can occur as an acute episode, or it could also be recurrent, occurring multiple times, or it could also be habitual. We call it habitual dislocation when you have dislocation occurring with every flexion extension. That is habitual. The recurrent is a dislocation where you have simply had multiple episodes but at different intervals of time, after 3 months, 6 months, 1 year, something like that. And acute traumatic is that single first episode. Okay, and this acute traumatic is the cause behind recurrent episodes. Habitual dislocation is a developmental problem. The structure of the knee is not okay. Fine. Now the golden point. If at all there is a dislocation of the patella, it will always be lateral. Why? Due to a lateral pull by the muscle called quadriceps. See, patella tends to be a sesamoid bone within the tendon of this muscle quadriceps. Now quadriceps originates from this anterior superior iliac spine, goes down and attaches to patella and ends up on the tibial tuberosity as ligamentum patellae. Now if you see the origin of quadriceps and the insertion of quadriceps, they are lateral to the patella. So whenever this muscle will contract, it will generate a lateral pull on the patella. In fact, this lateral pull is calculated by what you call as the Q angle, the quadriceps angle. Clear enough? So you get a torsion at the tibia, like the tibia twists externally. Like if you see here, the tibia is twisting externally. This will rotate the tibial tuberosity outwards. And now if the quadriceps contracts, more of lateral pull might dislocate the patella laterally. So dislocation of patella is always lateral. Now once the patella dislocates laterally, on the medial side you have a medial patellofemoral ligament. Medial patellofemoral ligament tears, and if it does not heal conservatively, you land up with recurrent dislocations. So recurrent dislocations occur from NPFL tears that are not healed. So clear? So first episode will be from this injury, like here. After the first episode, we'll have a lateral subluxation of the patella, this gentleman, because in this injury this Q angle increased as the tibia rotated outwards. The Q angle increased. He had the first episode. He did not take the right treatment. He kept on playing. MPFL, medial patellofemoral ligament, holding the patella medially, did not get much of time to heal. It remained unhealed, so he'll start having multiple episodes, and there'll be recurrent dislocation of the patella. So are you guys clear with all these points here? Fine enough, guys. So I hope things were clear enough to you. Any queries, you can please feel free to ask me from the session today. Anything that was not clear to you, you wish to discuss with me. So I hope you guys are thoroughly clear with these concepts on dislocation of the patella also. So I hope you've understood in acute traumatic episode will be conservative treatment, because you want this MPFL to heal. So you'll give some rest to the patient. But if patient does not take rest, he has recurrent episodes, you will need to repair or reconstruct the MPFL. So you've understood the treatment also, I suppose. Fair enough. So I hope you have understood the treatment part also. Fine enough, guys. So you wish to attend more classes, please feel free to go ahead with subscribing at Unacademy. That is what I would recommend. Okay. Yes. Use this code to get your 10% off in case you wish to avail some discount. The subscription prices are right there on the website, and you will find them to be very, very economical, and then of course when you add on the referral code you further get a discount. And I hope you are clear about the iconic subscription also, that Unacademy and Prep Ladder, they are a joint venture, so you can avail heavy discounts by subscribing to them both together. Clear enough, guys? Fine. So of course I'll keep teaching. You subscribe and you get to see more of classes from my side. Okay, and how to subscribe is very much clear from the website. Okay, just taking you through some batches that are coming up. So this is a snapshot for the May batch 2022, so you can have a look. You can choose the batch you wish to attempt and then subscribe accordingly. This is the test calendar we have with us for the first and second week of May. So keep giving regular tests if you are a subscriber, and you'll be able to evaluate yourself, and the explanations are designed very beautifully to give you the whole material in one go. The previous year question bank is very well available with us at Unacademy, so take that advantage. At least don't miss the questions that have already come. Okay, a mistake should actually become your memory by practicing these papers. Okay, you build up with all these previous year question bank papers your knowledge. So many previous year questions to practice. So get ready to subscribe, guys. The All India mock test is coming up on 14th of May. Getting up for the coming exam, make sure to prepare for it. Okay, many new offerings at Unacademy, so do not miss to check it out. Fine enough, guys. That's all from my side. My referral code OrthoLive, just in case you wish to subscribe, to get you 10% discount. And when I'll come next live, okay, so I'll be live soon. The date is yet to be decided. t.me Dr. Mukul Ortho. Maybe you can contact me here. This is a Telegram group on which you will get the updates regarding further sessions. Fine enough. And regarding your ring fracture and Jefferson fracture, I'll clear that up to you. Jefferson fracture is a fracture of C1 vertebra. The first cervical vertebra is like a ring. It is broken anteriorly as well as posteriorly. So we call it a burst fracture because the vertebra is broken at multiple places. And it is the C1, first cervical vertebra. This is what you call as a Jefferson fracture. Comes to an orthopedic surgeon. But ring fracture is not dealt by the orthopedic surgeon, goes to the neurosurgery people. So what you have in ring fracture is a fracture of the base of the skull. Motorcyclists tend to have it. Okay, or sometimes fall from height also get that ring fracture. So ring fracture will be not our domain and not the right person to ask. So clear enough, Gautam, with your query also to an extent? And understood the Jefferson fracture from my side. And let me tell you the best part. When this vertebra fractures, fortunately these fragments don't go and hit the spinal cord in the center. The spinal cord generally escapes injury despite the fact that this is the burst pattern of a fracture. Clear enough, guys? Fine enough. So thank you. Thanks for the lovely comments. Hope you enjoyed the class. More things you wish to learn from me, please feel free to subscribe. So I'll take leave for now. Bye bye. Good night.